Zoom record. There. All right, there we go. I had stopped it because I didn't want dead air for 15 minutes. But anyway, with your projects, a lot of you've asked questions about, can you do an educational presentation on some of the, you can do an educational presentation on anything. So take whatever you're doing and think about what message you want to get across to whatever group you're going to be speaking to, whether it's physicians, patients, or students or staff. It really just depends on, your perspective on. So in other words, you're going to take, say, a fraction for this course of what you're doing for your end product, and just building on that. And hopefully what you'll end up with is something you can use later on. But nevertheless, you'll have a framework, and that's sort of the goal. The idea is to get those concepts out there and sort of massage them a little bit and make sure that you've exercised them, because the biggest problem in your capstone when you go to presentation is that, I don't know how many, some of you teach, some of you don't. So not having the experience talking in a group of 100 or 500 or 1,000 people, all of those different size groups present challenges for you. And so I think probably most of you are not going to be talking to 1,000 people, but the point is that you have to sort of change your dynamic of how you're delivering that information, because you can't possibly engage, like right now, if we wanted to, we could all be talking at one time and discussing things. You can't do that with 1,000 people. So it's gonna change how you actually do certain things. So don't get hung up on, I don't have an educational component. You can develop one. Trust me, I can talk about anything. I can come up with, sometimes I'll get a call and say, can you speak at this conference? I'll say, well, what do you want me to talk about? And they'll say, well, we want you to talk on charting, which is really generic. So I'm boring too. So the tact I would take on that was, okay, what are the problems with charting? So a couple of years ago, I had to do that. And so I developed this whole thing based on the legal ramifications of charting in certain. So I did a case-based presentation, and I presented cases that I've dealt with of how charting would get people hung up, particularly in EMRs, and end up before the board because it looks like they're using false documentation, or somehow manipulating the system. And that happens actually quite often now, unfortunately, with EMRs. But you can make it out of anything, trust me. Okay, did you have any questions before we go forward? Because what I want to do tonight, I want to try to get through the presentation really quick, as quick as I can, so we can ask questions. And I want to cover what's coming up for this coming week. Any questions so far? Okay. All right, I'm going to switch over to let me know if you can't see it, but I've got to push you out of the way so I can see my slides. Let's see. Okay, so what we're going to do tonight is look at analyzing effective instructional methods, because one of the things you have to do in your project this week is look at determinants of learning, and that begins by doing some type of analysis. So a lot of times people will say to me, or have said to me in the past, that all you do is teach. And this back when I taught on a regular basis, and I always laughed. I said, what do you mean? Well, that's easy. Just out of curiosity, I know a couple of you do teach. How many of you have ever had somebody say that to you? A practitioner would say, well, that's all you do all day is teach, and that's the easy part of doing what we do. Anybody? Okay, good. Because I used to get that all the time. And so, because respiratory therapists have egos, I would spend my weekends working in the hospital. So some months I would have 2 days off a week, because I would be at school 5 days a week. I'd be in the hospital 2 days a week. And then and of course I was only supposed to work every other weekend, but they inevitably would call me. So I ended up working 1 month, 27 days straight. And I'm sure most of you have probably done that too. And, but I have to laugh when they say, well, you're just teaching, it's no big deal. But in case you ever get that. All right, so the good part about this is you're already doing assessment with patients, and with education, it's no different. We assess. And the way it works out is, when you assess a patient, you're looking at variables, data, and you're evaluating, and you're able to give your fellow therapists feedback on improvement or not improvement. That's what you're doing with education. So it works like this, and you've got the learning process, the training, instruction, practice, and this is sort of a continuous loop. And the goal, of course, is to get the student or the staff or whoever you're talking with to whatever success goal that you have set. So I want you to think about something about your patients. That's exactly what you're doing. You're assessing them. You're even giving them feedback on how well they're doing through your evaluation. And that's important for them to successfully leave the hospital. You might end up doing some form of education at the bedside, but it's about sort of carrying them through that succession of the learning, the training, instruction, practice. Because if you're going to say treat a patient who has asthma and you have NBI ordered, and you're going to train them how to do that, you have to be able to go in there and develop a program for them to be able to learn it. Now, not everybody's going to learn at the same pace, so the feedback is important. And just like with assessment that we do with patients, in this case, we're identifying the learner, not the patient. The setting for us in the hospital is already chosen, but in an educational setting, you have to choose the setting. Do you want to work in the lab? Do you want to work at the bedside? Do you want to work? Where do you want to work with that concept? I think I told you last week, a lot of times what I would do is simply change up what I was doing depending on the course. And really, that's what you need to do. Collect data about the learner from the learner. And then that comes in various forms we'll talk about in a minute, and then involve members of the other team, just like you do with patients. You have patients you're giving a report on, or you have a situation that you need help with. You're going to involve your other staff members. So you've already been doing this whole process, but you haven't really thought about it probably in the concept of education. But everything you do as a respiratory therapist is really revolving around some form of education, whether it would be with patients or staff or other healthcare professionals. So what would that learning assessment look like? Well, with patients, you probably have more informal conversations, and you also observe them. You probably don't have focus groups, but that would be something you might use. And I think even some people had suggested using groups as a method of determining your strengths, weaknesses, part of your SWOT. And your questionnaires, possibly some of you mentioned questionnaires, formal interviews. And of course, you would do that a lot of times with patients, doing formal interviews for assessment, but you could do that with, there's all sorts of assessment forms you can use. But formal interviews, you're trying to drive to a certain point. And a lot of times you'll see that when we do evaluations, staff evaluations student evaluations, we might formally interview them about the procedure as opposed to more or less informal. With patients, of course, most of the time it's going to be an informal situation. So a couple of things you need to know about, we talked about last week, was the difference between pedagogy and andragogy. We also talked about hudagogy, but tonight I just want to focus on these two concepts because typically this is what you will see. You have a lecturer, the lecturer speaks, there's no questions, and you just sort of direct it towards the students, where the andragogy is much more self-directed. And we're going to talk about maybe some pros and cons of both, but the result is that what you want to do is get the information across where they can understand it. And that's where hudagogy comes in, where you sort of use the best of both worlds. But with andragogy, with adults, which will be the majority of the people you deal with, is important to realize that they come to you with a set of skills that they've already gained. And it's up to you to help them sort of translate those set of skills into whatever actionable thing that you want them to do. If you're teaching in a college, that of course would be trying to develop something along the lines of, how can I get, I had a student one time that had mechanical ventilation, was giving her a tough time. Well, I've had that quite often, not just one time, but this one particular student, she was a mechanic. And so I started talking to her she worked on diesel engines. And, you know, I had a ventilator it was sort of it was an old, it was an MA1, and we had a couple of other MA2s. And so I just let her take them apart. And once she saw the inner workings of it, she really kind of understood much more about it. And she actually was able to put how many of you ever used the 900C? Oh my God, I just dated myself. Oh, thank you, Heather. Okay, so the 900C, she wasn't the only one, but she was one of them that could put the ventilator back together blindfolded. Take out all the inner workings of it and then put it back together. And so we would use that exercise, just not because they were going to do it all the time, but back then we did have to take those ventilators apart. Today, you're going to send them down to biomed. But it was fun, I can tell you that. Okay, so with andragogy, it's much more of an intrinsic type of motivation that they have versus extrinsic. And at some point in this semester, I'm going to give you some information on motivational interviewing, because I think it's going to be valuable for you, for the patients, students, staff as well, to utilize that. You'll also be doing a gaps analysis. Now, you did a SWOT analysis, and the gaps analysis is sort of part one of assessment for what we call the ADDIE design. Gaps in knowledge between the desired performance and actual performance. I'm going to show you an example in just a minute. Lack of knowledge, attitude, or skill is what you're looking for. And some of you did that in your SWOTs, which was really good. So the gap is sort of focusing on what knowledge that they don't have, what knowledge do we want them to get, what are they unaware, what they don't, what as the saying goes, they don't know what they don't know. We want to find out what that is. So a gap analysis is a method of assessment. So if you were to think of, if you think of it like a patient situation, you know, the gap in their healthcare, you know, do they have the device that they need at home to deliver the medication? Do they have the insurance? Do they have the finances? You know, do they have the support? Those are all gaps that might be there. You have to identify those. So you have what's currently going on versus what you want to happen. You want that patient to be self-sufficient. You want the student to be self-sufficient. You want that student to become a staff member who is self-sufficient. So this is where it comes down to individualizing it for a student. The SWOT analysis was sort of generic, sort of systemic, if you will, of the organization. The gap analysis is specifically looking at those gaps, because everybody's gap is going to be different. I don't know if you ever remember, anybody a fan of Rocky movies? You don't like Rocky? Gosh. Anyway, there was a scene in Rocky where Polly asked Rocky what he saw in his sister. And he says, I got gaps, she's got gaps. And what he was saying basically is that we're not perfect, and both of us are imperfect, and we just, that's what we're looking for. So what we're trying to find is sort of that sweet spot of what we want to improve upon. So we want to look at what is the plan that we're going to have, how we're going to implement it, and evaluation and follow-up. So this last part of the gap analysis is part of what we call the ADDIE design, which we'll cover later. It's also in the reading for this week as sort of an overview. I would encourage you to look at that, because that is sort of a more comprehensive assessment. So we're doing the gap analysis sort of as a subset of that. But the nice thing about the gap analysis is that you'll get a handle on maybe some of the things you need to really super focus on. This is just another training needs assessment model. I'm going to skip over this. Basically, it's just showing how it sort of fits together: training content, audience, the job analysis, learning outcomes, skill gap analysis, learner analysis, and the training solution. So it all kind of comes together at the end. And when we cover the ADDIE design, that will get more specific on the assessment, the development, the design, implementation, and evaluation, that's what it stands for. So inputs and outputs, things that you need to look at. If you're working with staff, and this is just one example, it could be patients, whatever. Job descriptions, staff requests, quality assurance reports, chart audits, federal professional rules and regulations, self-assessment, all the things that you need to look at to say, okay, what do we need to focus on? Just recently, I had a case where a practitioner worked for 3 months in a hospital without a license. How many of you think that's a gap somewhere? How did that happen? So the hospital had to conduct an analysis, a gaps analysis, basically, of how did this happen? And they had to come up with a plan of how to correct it. Does anybody know the consequences of that? Aside from the fact that there's a lot of, it's a misdemeanor, but on the hospital side, does anyone know what the impact of that would be for the hospital? Because we can't do anything for the, against the hospital. What do they have to do? Any guesses? How many patients
else have their license?
Who said that? Is that Heather?
Amazing, Naomi.
Oh, hey Naomi. Okay. What did you say?
I was just saying maybe they have to then prove that everyone else has their license.
Well, that do. But all right. So how many patients have you treated in 3 months? Do you even know?
118.
118. Okay, good. So 118 patients that you treated, every single one of the treatments, charges have to be reversed. Yeah. On top of the fact that if you did it in our state, it would be a $500 fine.
Yeah.
But you would have to pay on the first offense. Well, excuse me, it's $350. But anyway, the $500 comes in with the payment for the license itself. But in the second offense is $750, and third offense is $1,000. At some point, though, hospitals that happens to, if they don't report it or if they don't correct it, but it's found in an audit, they're in serious trouble, and it costs them a lot more than reversing those charges. So just food for thought. That's they had to do that gaps analysis, and what they found was that HR was handling it, and HR shouldn't have been handling it. So the manager just the other day called me to verify some licenses that he couldn't verify while Joint Commission was sitting in front of him.
Sorry, Dr. Croft.
Uh-huh.
Your volume keeps going in and out. I don't know if it's because you're not close enough, but I've turned you way up and turned you way down. And so I don't know if that's happening with anyone else, but I just wanted to let you know that.
Let me try this. Can you hear me now? Let's see.
I hear you the whole time. It's just the volume fluctuates, and so just have to offset with our own personal volume.
Okay. Because what I have is I have this system that actually transmits through my bones. So it sounds very loud to me. So when you talk, I mean, it's like blasting in my ears. I don't know if you've ever used anything like that, but let me know if you still can't hear. I'm going to, I've turned it up as far as it will go, and I will see what I can do for next week. I'll have to maybe buy another headset. Maybe it's not working correctly. This is an example of what a gaps analysis would look like in the ICU. So you have new monitors that have been purchased to ICU, and some of you are dealing with new equipment. And this is obviously for nurses. Nurses know how to set up and use the monitors accurately, but the nurses don't know how to use the new monitors and what's the gap skill. Knowledge have had not exposure to them. That's bad English, but anyway, have not had exposure to new monitor, do not know basic features of the monitor system, skill, don't know how to use the monitor, practice, have not used the monitor in patient care. So you can kind of see what they're doing here. So, I mean, this seems pretty obvious that, with a gaps analysis, it's pretty simplistic. You're looking at what's the problem, what's the gap, what's the solution. So the solution is the majority of nurses in ICU have no experience. Well, that's not the solution, actually. That's the methods used to identify the practice gap. The next part would be the solution, which comes in with the added design. Something similar to that is one for patients, pediatric patients. I don't know if you can see all that, but you can read over that, and you can go back to the slide later on to observe it. But you can kind of get an idea of how simplistic it is, and it makes it very easy. You need to, if you're going to do a gaps analysis, you really need to do it on this type of grid because it will help you see everything in alignment. And alignment with these things is really important, so you make sure you stay on task. In a course planning situation, for example, you're dealing with patients, 40% of the patients 65 and older in our community health clinic are receiving the pneumococcal vaccine consistent with national guidelines. Desired state, 100% of the patients 65 and older in our community health clinic receive the pneumococcal vaccine consistent with national guidelines. Identified gap, 60%. Gap due to knowledge or skill, knowledge, unaware of updated guidelines, and then methods used to identify chart audits. So you get an idea of again, this is step one of that ADDIE design. That's where it begins. You've got a problem you're going to solve. You need to know what the problem is and what the gap is. Now, once you've identified what the gap is, you have to ask yourself, what is the readiness to learn for the people that you're dealing with? In other words, there are 4 aspects that it actually revolves around, and this is called the peak method. And honestly, it's not quite broken down this equitably, because it'll be slightly different for everyone. But in general, 25% of each of these categories, physical, experiential, knowledge, and emotional, these are all things that you would look at. Going back to learning theories, talking about social determinants, talking about emotional behavior, all of those things that come into play with learning. So readiness, how ready is that person to receive the information? And there are things that will actually block their ability to learn. So for example, physical readiness. Now, the measure of ability, complexity of task, health status, even gender, you might say, well, why gender? Well, because there might be some tasks that might somehow, we're all equal, but we know that sometimes, for example, males are typically have very low, a very low pain threshold. As an example of a difference in genders. And that's because typically women have a much higher pain threshold. So there are differences that we need to look at. Emotional readiness. What is the emotional readiness of an anxiety level, support system, risk-taking behavior? What's their frame of mind developmental stage? What's their experiential readiness? And this is where we're working with adults, it's really important, particularly with andragogy, you need to look at. When they come to you, how ready are they to learn? I used to tell my students that the biggest thing for me was to know, did they desire to learn? And if they desired to learn, then they could do it. It's a matter of whether or not they had a very strong locus of control, which is, are they internally or externally controlled? In other words, if they're internally controlled, that's the type of student you would like to have in your classroom. You would like to have that in your staff members. You would like to have that in your patients. Now, patients, unfortunately, a lot of times will not have a locus control that's intrinsic. A lot of times it's extrinsic, as will staff or even students. What's their knowledge readiness? Now, we can't ignore the fact that we actually have to look at things such as, what is their current knowledge? Because how many of you have patients that are inhibited based on their educational level to be able to learn some of the things you're teaching them? If you don't recognize that, and it's not, it's not a dig on the patient, but if you don't recognize that, you have to have some way of adapting. If you don't adapt, then you're not serving the patient. So make sure when you look at that, you're looking at it objectively and saying, well, they only have a 7th grade education. I'm not going to be talking to them about, how bronchospasms occur. I'm going to be talking to them about how they feel when they can't breathe, because they can understand that. Same with children. You wouldn't talk with them at a higher level. Now, if you're talking with staff members or students, you're going to shift that level of knowledge way up. And this is a comparison of the pedagogical and andragogical method. And again, what I will do is, I think I can do this. I think I can post both the recording and all of the slides into the same in the same presentation on the course channel, so you can go back and review this. But ultimately, with the andragogical principle is that the student is self-directed. And what we want to do is find out how to get them to that point if they're not at that point. You know, if a student comes to you and they're not well self-directed, would letting them loose in the lab after you maybe show them how to do something, or even a staff member, if they're not very self-directed, would you just let them loose and let them practice and see what they come up with? Or would you go in there and direct them? What's your choice? What's your best guess? Anybody?
Oh, sorry, I didn't hear the question. I was yelling at my.
That's okay. The question is, if you had in other words, when we're talking about self-directed learning, if you have a new group of students or even a new group of staff members, do you show them how to do something and then just let them practice on their own without any direction, or would you maybe be standing by to give them some direction?
I'm more of a show one, do one, teach one, or, you know, whatever order that goes.
Right, exactly. And that's actually a really good idea, because when you have that show one, teach one type mentality, you're not going to just let them go in there and practice, you know, willy-nilly. You're going to have them go in there and you're going to show them, you're going to let them practice. And I always encourage my students to make mistakes. And they would say, well, I don't want to make a mistake. Well, to me, if they're making a mistake because they're trying, then that was giving them practice. Now, the goal was to just get them to do the procedure. And a lot of times when I would flip the classroom, I would go down and show them how to suction a patient, for example, before I talked about all of the ins and outs. And I would let them play around with it. And then we'd go back and talk about, well, this is what happens when you break, sterility, and we start talking about how, they can have infections and pneumococcal, nosocomial infections and all sorts of stuff. And they can see it a little bit better that way. And then we go back and practice some more. But, what is it? Practice makes perfect, right? Or is it perfect practice makes perfect? That's the better way to look at it. So I used to like to have them make mistakes so they can learn from their mistakes. The idea behind making mistakes is not so they can continue to make them. That is a danger of that. So with adults coming to you with a lot of this sort of background, like I mentioned, the mechanic, or I had paramedics and EMTs, I had medics, I had all sorts of people coming into our program. Each one of them come with a different set of skills, and we just have to learn how to sort of access those skills. And what I found out, what was really interesting about Army medics, one year I had 3 in 1 year, which was unusual, but they were very unsure of what to do unless I told them exactly what to do. Does that make sense? Okay, because they were in the military, they took orders. And I had several of them come up to me after some of the classes and said, gosh, if I had known what I was doing, I would have been scared to death, because they're taught how to do something, but they're not taught the why behind it. So for adults, the why is particularly important. Why are they doing this? In the military, they just want you to do it. Let's see, readiness to learn. Any change is likely to trigger readiness to learn. The need to know in order to perform more effectively some aspects of one's life is important. Ability to assess gaps between where one is now and where one wants to be. This is what's good about working with adults, is oftentimes they know where they want to be, but they don't know what their gaps are. So you have to sort of help them find those gaps, as Rocky said. Okay. So what evidence exists regarding the learning style principles? Did y'all find out? Any guesses? I think you knew my bias from some of the way some of you wrote your papers.
I saw that like most people's learning styles were multimodal. Nobody had just one set of style typically.
Yep, exactly. So what does the research say, I guess, is what I'm driving at. In other words, there's a good article that I've referenced in this presentation called "Do Learners Really Know Best? Urban Legends in Education." I don't know if I put that on the reading list, but anyway, urban legend number one, learner. So you know what an urban legend is, right? Is it true or false? True or false? Urban legends.
False,
Yeah.
like wise tale.
Right. So some might call it fake news. Okay. So learners as digital natives who form generations of students knowing by nature, this is what the summary of the article says, by nature, how to learn from media and for whom old media and methods used to teaching no longer work. And that's sort of the mentality, particularly of the millennial generation. And it's simply not true. There's no evidence to support that. This is my favorite. Learners have specific learning styles. Education should be individualized to the extent that the pedagogy of teaching and learning is matched to the preferred style of the learner. Now, if you have, whoops, I advanced it too quick. So with that last one, how could you possibly do that? If you have 20 students, 30 students, or in some cases, if you're working for a major university, you might have 100 students. How are you going to match your learning and teaching style, your teaching style to their learning style of 100 different people or 20 different people?
Maybe just multiple and hope you get a bunch.
Yeah, you sort of have, yeah. So you're going to take sort of a broad spectrum approach, right? You're going to think about those things, how to touch on, what would work for each learner. But the reality is that everybody is all three of the major learning styles, right? Now we can get into the other nuances, but of the three learning styles, there's really no way you can be in our field unless you have both visual, auditory, right, and kinesthetic ability. So you're going to learn all three ways. What you have to do is, and this is what I learned about it, is that where flipping the classroom came in so handy, is I was able to mix it up every day. And I think that's the key, because stimulating learning means that you have to stimulate interest. And so I had to come up with different ways of doing that. And so maybe today wouldn't work for student A, but it worked for B, C, and D, and so on and so forth. So, if that student came to me and said, look, I just didn't really get it today, because I really learn better if I read the material. So I would tell them, well, go back and read the material and come back and ask me specific questions. Notice I wouldn't say come back and ask me questions, because a lot of times I would get questions like, well, I don't understand this. Well, what is this? This is a very ambiguous. So, I don't understand how a Venturi device works. Tell me what you know about it, and that learner will gain from that as well. It really is a matter of sort of, like you said, a broad spectrum approach. All right, so this is in my way again. All right, so the third legend, urban legend, is that learners should be seen as self-educators who should be given a maximum control over what they are learning and their learning trajectory. How many of you have children in homeschooled for the last year and a half on Zoom? How well did that go? Not well. I mean, in some instances it did, but what the educational field found very quickly was that they were underprepared for online learning. They had no idea. They had no standards. They had no development of syllabi, how they would teach a student who is a kinesthetic learner, because visual learners and auditory learners were probably fine, but if somebody was sort of on the, needed sort of that hands-on, they probably suffered a great deal. And most children are very hands-on. I mean, they'll learn a lot by getting their hands on something. Give them a cell phone, they'll figure out how to use it. But can you trust them to do evidence-based research because they know how to use the internet? Maybe everything on the internet's real, right? Everything on the internet's true. And that's the problem, is that you have to be the guide, whether you're working with students or you're working with staff. You have to be that guide beside them to say, this is what we need to work on, and this is how we need to approach it. You're not there to stand over top of them, but you are there to guide them. So what really determines learning? Any guesses?
Interest?
Yes, I would say interest, desire. Yep,
The need to learn something?
perfect. Deep meaning must be in the goal to achieve a desired outcome. And I don't know how many of you studied Socrates, Aristotle, or Plato, but that's where the Greek philosophy of education comes in. What we want to know and the questions we want to answer are what, where, who, when, where, and why. We want to know those six things. There we go. Those 6 things. We want to know what it is, where it is sometimes, who, or the why, or the when, or that. We have to answer those questions. In other words, it's about curiosity. It's about the desire, right? And of course, that all comes from Aristotelian perspective, also called the Socratic method. When I was in graduate school, we had to, much of our leadership courses were based in Aristotelian philosophy. And so we had to read Aristotle's original works, translated from Greek into English, but we had to read the original works. And it was fascinating because many of the standards of his philosophy, whether it be about, the way we look at education, have stood the test of time. So many of you are, I'm sure, have probably gone on rounds, right, with physicians when you were in school, or maybe you're doing it on a daily basis. Well, what do? It's a question and answer type thing, right? They discuss. They ask questions about, well, have you thought about this? And, people will pontificate about all sorts of things. In other words, that's really what Socrates was doing with his students. He was just sort of talking off the cuff and philosophizing, if you will. But basically, it's about, trying to come up with a way to solve a problem through discussion. And this is a lost art. So this is just some examples of the Socratic seminar, if you will, what the ground rules are. 1, speak so all can hear you. Listen closely. Speak without raising your hand. Refer to the text. Talk to each other. Ask for clarification. Invite others into the process to speak. This comes back to using groups. In some of your discussions on, where you, or some of your papers where you were talking about, talking with staff members. This is sort of the idea. Consider all viewpoints and ideas. So you don't dismiss anything. That's called brainstorming. Sticking to the point under the discussion. Now, oftentimes when you're in a discussion, particularly in a board meeting, we'll use something called Robert's Rules of Order. So the point of Robert's Rules is to keep whatever discussion you're having on task. And if the discussion gets out of hand, meaning that it kind of goes off on a tangent, a board member might speak up and say, call to question. And what that does is it stops discussion. All discussion at that point, we come back to the original discussion and you vote on that. Because so often when you're talking in groups, particularly in a staff meeting, for example, people will start complaining. And I found it very effective to use Robert's Rules in anything that I do with a large group, because that keeps people on task. It seems a little autocratic to some people, but you can move through a meeting very quickly and avoid getting tripped up on, just minor issues or in a gripe session. I used to hate that when students would get in a gripe session, you couldn't get anything done. But in a board type situation, we would use Robert's Rules to control that messaging. Know that you're responsible for the quality of the seminar. So in other words, a lot of times, you have these outcomes. Yes.
What's the Robert's Rules? Is it these 5?
The Robert's Rules for conducting a meeting. And you can look it up online, but basically Robert's Rules are a set of guidelines to conduct a meeting to ensure that the meeting is run efficiently. Because when you're talking about, say, a large board that I've been over before and the one I'm currently in, if you have something, a discussion going on, it can get really out of hand because people start talking about things that are not germane to the conversation, and it derails the whole process. But that doesn't mean you're going to ignore what they have to say. What you're going to do is maybe table what they're going to say and move it to a different conversation. And, just respect the fact that, everybody's talking about this one topic that we're going to deal with. And, if you're talking about, I don't know, something else that was came up that day, it's irrelevant to the conversation. Like I said, it is autocratic to some people, but it does keep things moving. So step one, determine the objective. Step two, teach through questioning. So you're going to ask a bunch of questions. You're not going to just, you're going to just ask questions, sort of exercise or massage the conversation. Practice before you assess. So whatever you're going to do, you're going to practice whatever skill they're going to use, get them an opportunity to refine those skills, and then provide feedback after they refine those skills. And this process continues. So if you have somebody who fails at, say a procedure, or you have somebody who fails at doing something, within your organization, when you go through this process and you continuously develop their skills, you're correcting them in a gentle way. But what's interesting is that this is also part of the critical thinking. This is the critical thinking process that we need to be teaching students. It's not about getting the information, and in other words, it's not about reading it one time and getting it, because that's what the goal of many students have, particularly when they come into respiratory. They want to be able to read a chapter and get it and move on. But that's not reality. And they need to understand that they have to constantly go back and refine that. You have to yourself understand how you best learn. They have to learn how they need to learn. The biggest gift you can give a student or a staff member, a young staff member, is the gift of learning how to learn. If you can teach them how to learn, it's kind of like if I give you the fish or teach you how to fish. If I teach you how to fish, you can feed yourself for a lifetime. If you teach them how to learn, they can learn for a lifetime. And that's how I always approached it. And I would drive them crazy with questions. And they would sometimes look at me and go, well, you're never going to give us the answer. I said, well, you're doing really well on yourself. I just want to make sure you understand what you're asking me for. And through that process, they would develop their own knowledge. So this is sort of a simplified method, and we've sort of covered this, but it's a cycle that you get into, and it says interrogate your ideas in number 4. And it's not about interrogating the person, although sometimes it might seem like that. But when we were in school, we did rounds with physicians, with the residents at Duke, and we would go in x-ray rounds, and they would interrogate us, literally interrogate us on the patients. And I can tell you that was the best learning experience I ever had, because I always knew I had to be prepared. Even if I didn't know the answer, I knew how to answer the question. And the answer to the question that you didn't know was, I don't know, but I will look it up. And so okay, they were fine with that. But what they didn't want us to do was guess. They wanted us to either know or know how to get that information. And that's what I learned from those rounds. We would do x-ray rounds with them every Wednesday morning. And the pulmonologist at Duke would interrogate us on each patient. Wouldn't even talk to the residents. He would just talk to us. So that was a little nerve-wracking, but it was well worth it. Here's what you need to know about learning, though. When you're talking about all the skills and the learning styles and things that we know aren't true, there are some things that are true. And that is, we just talked about the need to practice, the need to reassess, and the need to evaluate. And that's because memories are short. Look at this graph here. If you teach a student or a staff member a new procedure, now it's different for somebody who has experience versus somebody who doesn't. But here is within the first day of that information, look how far percentage-wise that they lose within the first day. Within 9 hours, that new information has not been retained. So less than 40%. So by the time, so I always used to get so frustrated because I would think, I just taught you that yesterday. And you act like you've never heard it. Well, this is the reason why, because memories are short. And if they don't practice with that information, they're not going to retain it. So when we're talking about all of these fancy things, learning styles and everything, it's how that it gets lodged into the memory. So we have 4 stages. We have the attention stage, the processing stage, the memory stage, and the action stage. Now, what's important about this is that when you get into the action stage, that's when you really get into securing it into the long-term memory. That's why it's important that you have sort of this, here's the information, here's the concept. It gets the wheels turning, but it takes some action on their part, which is they need to read the information, obviously, but they also need to work with that information before they can store it in their memories for any long-term method. If all they do is read the textbook or read the procedure or the policy or the protocol, or you hand a patient a piece of paper and say, here's your instructions for how to use the MDI, how many of you think will use the MDI correctly? 0. That's the problem. That's why when you go to, when you look at MDI, people sometimes I think MDIs are taken for granted. It's an easy thing to use, right? All you got to do is suck on it. Okay, number one, we don't suck on anything. That's the problem. We want to deeper breathe, right? So, but the patients are told things. I actually had a patient one time with, I can't remember which DPI it was now. It's one of the first ones that came out. I went to go check on them because we had to reevaluate them after 24 hours. And I went in to check on how they were using their DPI. It might have been, God, I can't remember now. But so what they did was they clicked, they put it on their hand and they licked their hand. I said, why did you do that? And they said, well, that's the only way I knew how to take it. I said, well, who told you how to take it that way? He said, well, nobody. So they weren't even taught how to use the DPI. But what he saw was when he clicked it, he thought he saw the white powder. So he figured, well, it's white powder. It's like a pill. I take it in orally. We corrected that. But anyway, he wasn't even taught. But then you have people that are taught and they will forget by the next day. So just remember that with your patients, they're going to come in with various different levels of education. Your students are going to come with very different levels of experience, and they're all going to retain knowledge in about the same way. But you get them to practice with it, and that knowledge level will go up. So get them into that action stage as fast as you can. Now, as we close tonight, we're getting to the point where you're going to be developing your goals and outcomes for your project, if you haven't already done so. And I just want to remind you that we use something called Bloom's taxonomy. And I think I mentioned this last week, and I'm going to keep coming back to this until we actually get, I think it's week 4, actually, when we get into that a little bit more. But do you remember the purpose of Bloom's taxonomy? How are you going to use that? So with Bloom's taxonomy, let me ask you a question. Would you want a patient to be at this level, or would you want the patient to be at this level?
This level.
Okay. So would you want a student to be up here, or would you want a student just to stay down here?
Up here.
Okay. So what you're going to do when you write your goals or outcomes is you're going to begin the sentence. The staff members, the students, whatever, will be able to design a care plan for a patient with COVID-19. Okay. They will be able to select the appropriate equipment to properly treat the patient with COVID-19 and ARDS. In other words, you get really specific. Okay. Of course, you want them to be able to differentiate between a patient who has ARDS maybe CHF or whatever. But the whole idea is that you want to stay up in this upper echelon of things that you want them to do. Now, if you do that, then what they have to be able to do are these phases: remember, understand, and apply. Because they can't do the top unless they can do the bottom. So when you're writing for staff, particularly, you want to be in this upper three. If you're writing for students, you might be here if you're on up. And then if you're writing for patients, you're going to be want to get to at least remember, understand, and then apply. And again, that'll be varying, how much can they apply? Sometimes you have to involve family members if you're talking with patients. With students, though, you not only want to be able to apply, but they have to analyze what they're doing, evaluate. They have to self-evaluate. We have to evaluate them. But ultimately, they have to be able to create something in the end. Now I say create, create is sort of ambiguous because we can have them set up the students will be able to assemble the servo ventilator in order to properly treat a COVID-19 patient with ARDS. Okay, so if you want to get that specific, the more specific you can get, the easier it is to measure. Measurement of the goal is so important. Your outcome, if it cannot be measured, it is not a goal. Or it can't, in other words, if you cannot measure it, or show me how to measure it. So how would you measure, for example, whether or not someone could assemble the ventilator? Well, you would simply what? Look at how they assembled it and how they did what? How they what settings did they put them on? Of course, you wouldn't do it on a patient, but I mean, you would do it on a test lung. But you would be able to judge that, so the outcome is measured by a staff evaluation process or a peer evaluation process, or the supervisor assessment of their skills. So so you have to have, what is the outcome, which is how you're going to develop your objectives, and how are you going to measure that outcome, and is it measurable? You never want to write it out. You never want to write something that you can't measure. And I'm trying to think of a good example of, let's see, one I saw. I'll have to think about it, but I'll think of some by the time we get to, I have a couple of examples that I think are pretty interesting. I have a whole presentation on how to write goals for care plans. And some of the crazy things, if I can find that thing, I want to show it to you, because some of the craziest things I've ever seen in a chart in a care plan. And, how in their, I don't know what they were thinking when they wrote the goal, but it was not only were they not measurable, but in some cases they were offensive goals. And if I can find it, I'll show it to you. It's somewhat hilarious. But anyway. All right, so another way to look at this, and I may have shown you this last week, is how to look at, you mentioned see it, do it, teach it. Well, this is sort of the idea behind this. Breakdown of how maybe you should look at the learning process. We want to spend less time in lecture. You want to give them some reading material. You want some audiovisual stuff. You want them to demonstrate discussion groups. But where did they learn the most? By doing and teaching. If I could get students to tutor each other, they would excel exponentially, because they're forced to read more, practice more, and then have it reflected back to them. And I can tell you, if you have, that's why a mentorship program, if you're working with a staff, is so valuable, because if you have strong RTs that can teach others, and then they can teach these people not only the information at their skill level, and they can then turn around and teach others. And when you get people doing that, you get them excited about what they're doing. But if all you're doing is pushing a treatment or pushing ventilator down the hallway, and you don't see the value of teaching in what you do, and this is why it always excited me about working in the hospital, was I always found opportunities to teach. Even though I wasn't there to lecture, I would find an opportunity to teach them. I had an opportunity one time to treat my primary physician who treated me my entire childhood. He had pneumonia and he was having a really tough time. And I didn't know he was in the hospital. I just happened to be assigned to him that day. And so, you know, I went in the room and to my surprise, we started talking about everything. And so I said, Dr. Townsend, I said, I'm going to do a couple things with you, breathing techniques and, some chest physiotherapy. I said, but we'll see what works. And he got so much stuff up his lung. He just said he couldn't believe how much better he felt, because what people were doing when they would go in the room is they would just simply, tap on his chest. They wouldn't talk to him about how he's breathing and, how to expectorate properly. And we did also, I'm old school when it comes to CPT. So I would do every single breathing technique I learned, not only growing up in respiratory therapy, but also what I learned through some training that I did. And it was amazing how quickly, I could get patients to cough up stuff that were retaining secretions. And it wasn't anything I did necessarily, but the patient was willing to learn and I was willing to teach. And it was very helpful to them, but also to me, because every time I had a success like that, I became more convinced that the more you taught patients to help care for themselves, the better off they were going to be. He was discharged in a couple of days after that, because once he started moving his secretions, he was able to recover. So it was just, there's always opportunities to teach. That's why I said at the beginning of this, there's always opportunities to develop an educational model in what you're doing. And if I was on the floor, I was in, working at the college or wherever I was always in that mindset of teaching. In other words, in my mind, a respiratory therapist isn't someone who necessarily treats patient all the time. They're someone who's going in and consulting with what's the best way to treat this patient. And, maybe you have to do some of that or maybe not, but people oftentimes, I had students always tell me, they never saw in the hospital where therapists were really engaged in doing the kind of things that I was telling them. I said, well, you don't have to have an order to teach. If you've got a patient that has CPT, and why don't you teach them what you're doing and why you're doing it? Don't just do it to them, because when they learn about what you're doing, they might get more involved in their own care. And that'll change the dynamic quite a bit if the mindset's changed. So if you have more questions about what you're going to be doing, you're in good company. We're all there. I change up what I'm doing when I'm going to conferences versus when I'm teaching a group of students, or whether I'm going to talk with first year students or second year students, or whatever. I change my tactic on how I'm going to approach it, and depending on the setting. The answer lies within, as Socrates would say. In other words, your intrinsic motivation is what's really going to drive your teaching in any setting. Help your students, staff, or patients find their why, and the how will be easy. I helped a friend of mine with a Facebook group for about 5 years, and it was on the ketogenic diet. And I was sort of the science guy for the ketogenic diet. And I've actually got a book out on ketogenic diet. And so the biggest thing we would talk about is knowing your why. Why are you doing this? Because if you have a well-defined why, the how will be so much easier, because you won't care how hard it is, you'll just do it. If the patient is convinced as to why they're doing what they're doing to improve themselves, then teaching them how won't be a problem. Same with students, same with staff. If you tell a staff member, you know what, just do what I say, don't ask questions, that's the sure method to having a good therapist leave your facility or losing a good student, because ultimately they want to know the why. Adults have to know why. So don't ever forget that. Teach them the why. The how will follow. So when you do all of this, when you start really thinking about, sort of the principles of education, you really, we only have a compressed amount of time in this course. That's why I want to focus on things that are evidence-based rather than things that aren't evidence-based. We can learn all the theory in the world, but what you need to know is what will work, right? So hopefully some of the materials that are in the course will help you sort of zero in on that. And you're going to have to do a little digging to find out what works for you, because it's going to be a little different. But I wanted to show you real quick, if it is still there. Let me see here. Oh no, it's going to log me out. I had it up, but I knew it was going to time out on me. So. All right, well, we're at the end of the night, so let me just real quick go into module 2. I want to see something. Okay, so for module, what I did was, just so you'll know, I tried to break it down, things that would be applicable discussion, things that would be applicable to the module assignment. So with your module assignment, these are all things that I think you should review. They're not that long, but I think, again, it drills into what's really important. And I think it was this one I wanted to show you. If you know it, you can teach it. Good teachers are born that way, and then faculty teaches content. All right, so there are a lot of good, short tips here. And this one goes into using Bloom's taxonomy and setting cognitive objectives, which we'll get to it more in week 4. But I want you to explore some of these things, because I think, the more you explore around with it and mess around with it, the better you'll get at actually applying it into your project. Actually, what y'all did this week was really great. So I don't anticipate anything less than that. I think, everybody sort of latched on to what you were doing. Everybody had sort of a different take on things, but that's okay. That's what learning is about. Any questions about this week's assignment? No questions? Y'all are a quiet group. I'd rather you talk to me a lot. I got a question here. Okay. So it was the same thing about the volume. I'll try to figure that out for next week. All right. Well, if you are okay, we can call it a night then. I appreciate your time. Thanks.
Okay, my honey did that.
Thank you.
Thank you.
Yeah.
Good night.
Good night. What was that?
I don't know.
All right, I got to figure out how to shut this off.